All right. Welcome everyone to our Friday Chalk Talk. Um, my name is Kristen. I'm a hospice chaplain over at LA Home and Hospice, and I will be your moderator today. We're going to have a similar format like we usually do. Our presenter will speak for about 20 minutes, and then we'll have a Q&A afterwards. I will be managing the chat and can let our presenter know any questions you have via that medium. I am so excited to introduce our presenter today. Caitlin Kim is a chaplain resident at Aurora West Dallas Medical Center, and she is fond of hiking, writing, and her 6 delightfully energetic children. So Caitlin, take it away.
Thank you so much, Kristen. And thank you all for the opportunity to be with you this morning and to talk about something that I'm passionate about. So today we're going to talk about alcoholism in families, the impact on adult children, because that's who we usually see, and the implications for palliative care. Kristen, I'm going to ask you to help me be accountable to time. Thank you so much. So we'll start by looking at what is an alcoholic family system. We're going to go ahead and define it, and then we're going to expand our definition. So we're going to start with the 4 basic tenets of an alcoholic family system. This comes from a book published by Steinglass, Bennett, and Rice. So the first tenet of an alcoholic family system is that alcoholism and alcohol-related behaviors become the central organizing principle around which family life is structured. The introduction of alcoholism alters the balance between growth and regulation within the family. So the family is prioritizing short-term stability over long-term growth. Our third tenet is the impact is seen in changes in the regulatory behaviors as family life accommodates the demands of alcoholism. So again, that gets back to alcoholism and alcohol-related behaviors being that central organizing principle. The type of alterations in the regulatory behavior influence the growth and development of the individual members and the system itself. So as there are changes in the family life cycle, we find developmental distortions. So now that we have an idea of what we mean when we talk about an alcoholic family system, I want to expand that definition. So the idea of an alcoholic family system really comes out of the addiction and recovery movement, with both mental health professionals and researchers and people whose lived experience is an alcoholic family system coming together to really define that. And as that happened, particularly within the 12-step community, began to realize that it's not just alcoholic family systems that function in this particular way. It can include a variety of family types. So you can see from this really helpful graphic from the 12-step program, Adult Children of Alcoholics, that there are lots of different family types that can sort of operate in a very similar way. So we've talked about alcoholic or addicted families, families with perfectionistic tendencies. And those are families where shame is very operative and expectations are often too high, and praise is typically tied to an accomplishment rather than given freely. The same system can happen with a hypochondriac parent, where we have sexual abuse or incest. where a parent is dealing with emotional or mental illness in a militaristic family. This is one perhaps that touches close to maybe the purview of the chaplain, where we can see the way that religion or other types of thought can operate as a kind of dangerous central organizing principle. One that's not on this list, and I want to lift up that this list is not inclusive. I imagine that if we sat together for a little while, we could come up with a bigger list. One that I want to add for our purposes is chronic illness. Chronic illness of a family member can act as a central organizing principle, and cause a lot of dysfunction, distress, and chaos in a family system. So I'd like us to keep that in mind as we move forward. So we're going to look at this. This is a lot to look at. And so we're not going to spend a long time here, but I wanted to offer this image to you. This image is showing kind of how a family works as a system. So this is an image from John Bradshaw's book, Bradshaw and the Family, A Revolutionary Way of Self-Discovery. Bradshaw is a psychologist whose work really puts forward the idea of family as system, and that it's a system that's always trying to balance itself and find stasis. Now, this balancing that a family system does, this can be a source of resiliency and stability in a healthy family. However, it can work to maintain distress and dysfunction in an unhealthy system. The system always is trying to get to stasis. And if stasis is dysfunction, it's always going to try to right itself to that. And sort of moving beyond this, I think perhaps maybe in our own lives, in the lives of our patients, we can also see that these systems not only impact the family or the individual that we might be sitting across from, but these systems, these ways of being, whether functional or dysfunctional, have an intergenerational impact. So now we'll just take a brief moment to look at the roles in an alcoholic or dysfunctional family system. And I have the word survival here, and that's just to remind us that these are not necessarily roles that people choose or are aware that they're playing, but ways that individuals within a system learn how to survive and function. So here are the survival roles. And this image is talking particularly about addiction. We have number 1, the enabler. Number 2 is the hero. Number 3 is the scapegoat. 4 is the lost child. And 5 is the mascot. And I'll talk a little bit about each of those individually. And I'll start off by saying that in many family systems, the enabler, or as it's sometimes called, the chief enabler, is often a spouse, though that role can certainly be filled by a child or another family member as well. So we'll take a minute for each of these. The chief enabler is the protector of the family. On the outside, the chief enabler will seem self-righteous, super responsible, sarcastic, passive. They could be physically sick or take on the role of a martyr. What's happening inside can be hurt, guilt, anger, low self-esteem, and I'll add to that shame. The next is the family hero, sometimes referred to as the hero child. This is, in a lot of family systems, usually the firstborn child. On the outside, This is the good kid, the high achiever, the kid who follows the rules, seeks approval, and is very responsible. Inside of the hero child, we find hurt, guilt, inadequacy, and I will add probably to all of these, shame. Next, we have the scapegoat. The scapegoat is sometimes referred to as the problem child. On the outside, the scapegoat is hostile, defiant. The scapegoat is a rule breaker and often finds themselves in trouble. Inside, the scapegoat is experiencing rejection, hurt, guilt, jealousy, anger, and shame. Next, we have the lost child or the forgotten child. Outside, the lost child is often shy, quiet, very much sort of submerged in their own fantasy life or their own interior life. They can be solitary. They can be seen as mediocre. They can also be seen as kids or grown-ups who attach to things more so than people. Inside, and we're seeing a lot of commonalities here: rejection, hurt, anxiety, low self-esteem, and shame. Next, we have the mascot, who is the family clown. In a lot of families, the mascot is the youngest child. But again, there can be a lot of fluidity in these roles. So outside, the mascot is immature, fragile, cute, hyperactive, sometimes physically sick, distracting. Inside, insecurity, fear, anxiety, and depression. So we've sort of looked at these roles. We've looked at the system, how it operates, why it operates that way, and who are the individuals in a system, and what roles do they take on. So now we're going to look a little bit about the impact on adult children. This is from, again, from adult Children of Alcoholics, which is a 12-step program. This is part of their literature. These 14 traits are referred to as the laundry list. There is also a reverse laundry list and the other laundry list. So if this is something that interests you, I really encourage you to check that out, because some of the underlying struggles and emotions detailed in this these 14 traits can actually have an opposite that is equally powerful. I'm just going to go back here. So I'll share some of these because I dislike slides with a lot of text on them. So in 12-step, use a lot of we language. We become isolated and afraid of people and authority figures. We became approval seekers and lost our identity in the process. We are frightened of angry people and any personal criticism. We either become alcoholics, marry them, or both, or find other compulsive personalities, such as workaholics, to fulfill our sick abandonment needs. We live life from the viewpoint of victims and are attracted by that weakness in our love and friendship relationships. We have an overdeveloped sense of responsibility, and it is easier for us to be concerned with others rather than ourselves. And this enables us to not look too closely at our own faults, etc. We get guilt feelings when we stand up for ourselves instead of giving in to others. We became addicted to excitement. We confuse love and pity and tend to love people we can pity and rescue. We have stuffed our feelings from our traumatic childhoods and have lost the ability to feel or express our feelings because it hurts so much. Denial. We judge ourselves harshly and have a very low sense of self-esteem. We are dependent personalities who are terrified of abandonment and will do anything to hold on to a relationship in order not to experience painful abandonment feelings, which we receive from living with sick people who are never there for emotionally for us. Alcoholism is a family disease, and we became para-alcoholics, which is the first term used for adult children of alcoholics and sometimes for codependents, and took on the characteristics of that disease even though we did not pick up the drink. Para-alcoholics are reactors rather than actors. So with all of that in mind, I'd like to welcome us into a conversation about the implications for palliative care, addressing the wounds and needs of the patients we serve, their families, and maybe our own in the mix of that. So I have a question for conversation, and I hope we'll get some good conversation around it. And that is, what does a systems approach have to offer in terms of our practice of care to patients and families? So how does our understanding of family as a system, either an unhealthy or healthy system, impact the care that we give and that we offer as care providers?
Kaylin, this is Liddell. It's funny, me and Matt were having a similar conversation just minutes before we popped on about family systems, and how does that impact religious beliefs. So we were talking about a paper that we're writing. I think this impacts palliative care similarly, in that patients who are sick, especially palliative care type patients who are facing some tough choices about their health, their life, always are looking at the situation probably from, what do I do next? And who's going to support me in this, even if I'm dying? Who do I have in my corner? Or do I have anybody in my corner? Or I don't have anybody in my corner for all the things that I did to them while I was either on drugs, alcohol, or just being a bad parent, being a bad brother, sister, and not treating people with the love and care that they deserved, or those 14 things that you just kind of named. So I think it impacts palliative care in that if we can identify that, I'm drawing to palliative care as a chaplain. I really am. I think that's where I'm going to continue my practice, right? If I can offer a patient an opportunity to see that his life still has meaning, even though he's in a bad situation or she's in a bad situation, and that, they can still find a way to build a bridge to some past hurts and pains, so that they could actually rest in peace, so to speak. I think that goes a long way into mending dysfunctional families or situations, and it can be the start of healing. Even if that person doesn't live, those who are left behind can, because they heard, I'm sorry, or got whatever they needed from that person before they expired. So that's just a thought, just one.
Thank you, Liddell. I really appreciate that. I like how you're sort of picking up on sort of the needs of the individual and the needs of the family. And I think sometimes I'm thinking about the way that we conduct family meetings, and how sometimes we can, or I can, maybe focus on the patient and maybe get a little bit of tunnel vision. And I think bringing a family systems approach can kind of give us a bird's eye view of what's happening in the room. How are people relating to each other? How are decisions made? What's the pull? What's stasis for this family? What's and what's the pull that's happening in this moment of crisis towards their normal, whether that's healthy or unhealthy.
Yeah, agreed. Matriarch, patriarch, who does the family look to for strength and answers or choices? Who's going to make the decision? Yeah, I agree 100%. And I also think because most people, not all, have some kind of religious background or religious system, it's easier to pick up on that as well, so that you can help them navigate that part of it as well. So yeah, good stuff.
Thanks, Adele.
This is Sue. I can think of a situation where I had a patient who was an alcoholic, and when I asked the family about their relationship, the sideways look that they gave each other was one that the parent was a terrible parent. And, they were faced with end of life decisions. And as you mentioned, there's shame, there's just a myriad of emotions involved, and just to be able to listen to them and say, you know what, it's okay. It's okay to be at end of life, and it's okay to even be glad that you're to this point, and to acknowledge them that they're whole beings, even if they came from this very dysfunctional family and they didn't like the patient.
And Sue, I hear you in your example normalizing and humanizing their experience, and what a powerful counterpunch to shame that is.
Mm-hmm.
Caitlin, in palliative care, there's a saying that says people usually die how they live, and sometimes it gets worse at end of life. People lean in to the things that they've done in the past, and so being prepared that these family meetings, things may actually get worse, and so perhaps having a chaplain or a psychologist or a social worker present in some of these family meetings to identify things and have the skills to help address it. Because I don't know that we all feel comfortable being able to navigate some of those dynamics.
Absolutely, and they can be really tangly, kind of scary, those dynamics. But I wonder, whatever our practice is in the meeting, whatever our area of expertise, maybe taking a moment to step back and to look at, again, to sort of take that bird's eye view in the room and look at the dynamics that are happening and what that tells us, I think can just be really helpful and help us maybe understand the individual a lot better.
This is Betty Malloy, and I'm a chaplain. And one of the things I think about is that it took a lifetime for this system to develop, and we're not going to change it at the end of a person's life for that person or for the family. And so what happened has left tremendous results, consequences. But are there ways that we can offer some sort of support that does not exacerbate the system, but that does provide support to the people who are in the room at that time?
I think those of us in caring professions often like to fix things for other people, and we can't fix it, but maybe we can help understand it and get the best results for the people, the individuals within the system, that we can. And sometimes that limitation is hard.
And sometimes I think the compassion that we offer to each person can begin to open gateways to build something new. So the compassion we might offer to the patient, whomever they are within the system, might be one way through our compassion and kindness that we open a door to something different. We won't fix it, but we can open the door.
That's a great point. Thank you.
Caitlin, as you were presenting, particularly on the militaristic and perfectionistic family systems, I thought back to our palliative care discussion it was a while ago, on the limits of militaristic metaphors for engaging with the disease process.
Yeah.
And I was thinking about how, as a chaplain, I might zealously want to assist in reframing the patient's thought and language there. But if I can have an eye to the relationships that made those metaphors so powerful and plausible, so this family system, then I might, perhaps my zeal could be appropriately tempered and might be able to provide even just a moment of empathy. I'm thinking of, in your description, you talk about shame being at the root of all of these things. So when I'm hearing an almost militaristic resistance to, say, palliative care or hospice or things like that, comments about that family members or patients have made about giving up and having to continue the fight and that sort of thing, to translate in my mind, oh, there could be shame here that I might meet with empathy, and who knows what that will do, but that's a big takeaway I got from this presentation.
Thanks for sharing that, Kristen. I appreciate that. So moving from patient care and our care of families to us as care providers, I have some curiosity about what you all think a systems approach might have to offer in terms of our own practice of self-awareness and self-care. So I can start by sharing a little. I am the adult child of alcoholics, and I am a hero child, and I really like to fix things for people. Understanding this systems approach has been really helpful to me in my practice as a chaplain, because it helps me to understand that about myself, and it helps me to understand situations and systems, other people's systems that draw me into that place of fixing. When I have that self-awareness, I can be curious about it, and I can make choices when I'm aware of what's getting activated in me about who I'll be with a patient or a family. And that to me links to my self-care, how I take care of myself as I offer care to others.
I think for me, this is Sue. I'm also an adult of a alcoholic, was going into this practice, my own biases, and, thinking, for patients, you got yourself in this situation, or, you cause this, and just step back and say, you know what, you're still a human. This is where we can grow and help, and really checking biases, because we have them, and to make a change can make a change in somebody's life that's just traumatic and dramatic.
That's great, Sue. Thank you so much.
Well, I wanted to say to you, Caitlin, and I'm also a hero child. I think in my family system, it's kind of funny if me and my brother, we've kind of started to take our own recovery from it seriously, and the more healthier that we try to be, the roles can switch. So like, then my sister can become the hero child all of a sudden, and my job's kind of out the window for a little bit. But I guess my point is that it's really hard to break away from it, because it tries to pull back in. And and like you, I'm also aware too, like if there's a family that I'm observing and is kind of dysfunctional in some of these ways, that I could maybe get assigned that hero role by them and be in it without knowing it. So that's why what you're saying is very important to me, and I just try to keep that in mind.
I appreciate that, Matt. It's really fascinating how the system is constantly trying to right to right itself, and that can make recovery really hard.
Rachel commented, I think in a team approach, we can remember to be compassionate and kind. Also remembering we can lean on the interdisciplinary team to help. Rachel, that observation is one I'd been kind of thinking about, how particularly for roles and people who tend towards a sense of over responsibility, that identifying our professional boundaries and limits and depending on others in the interdisciplinary team can be a nice way of counteracting that impulse to take responsibility for all of the problems.
Group, I'm a product of parental alcoholics on both sides. And you can add sibling alcoholics and drug addicts. And I am one who has went down the rabbit hole myself years ago. And I think to answer this question succinctly, from my own life experience, what does a system approach has to offer in terms of our own practice of self-awareness? My self-awareness is that when I walk into a room, I realize that whatever going on in them, I probably experienced already in some form or fashion. So there is no judgment for me, right? I mean, it's just compassion. And I think because I understand how easy it is to get off. But the self-care part, I'm learning that the codependency, it's easy for me to get locked into that when I walk into a room. When I see someone suffering from drug addiction, not taking care of themselves, whether it's high blood pressure, any of that kind of stuff, in any kind of way, because I've experienced it or am going through it, it's easy for me to get, locked in there. And I had to learn and trying to learn now that I cannot go into the room and not stay objective. Yeah, there are going to be some moments maybe where I might get some codependent issues, thoughts running through my head, but I can't express them. I got to leave the patient in a place where they can deal with their own stuff without worrying about what chaplain went through. And so I think that's the best part of my self-care that I can do, is realize that I can't keep allowing myself to be codependent in what's happening with them, and stay objective and do my best to just be present, compassionate, have empathy, sympathy, and more important than that, just be a good listener. So.
Thanks, Liddell. And I hear in what you're saying, sort of that urge to take maybe more responsibility than we really can, a recognition of that, and also a recognition of the power of letting people take responsibility for their own recovery, whatever that looks like. I appreciate that.
We are about at time. Caitlin, I wanted to give you an opportunity to make any closing remarks. And then Marty, if you have some announcements.
Okay. Well, I don't really have any closing remarks other than to thank you all for engaging in this topic with me. I know it's a difficult one, and I appreciate your invitation and your participation. So thank you all. I'm very grateful.
Thank you, Caitlin.